Okay, welcome everybody to our breakout session. Our first presentation is going to be building a patient-oriented, practice-based research learning community in BC, and we have three speakers, Christy, Kim, and Miranda. I'm just going to give you a brief introduction for each of them. So Kim is a knowledge translation and implementation consultant, and is that okay? Okay. I thought I was reading the wrong one. And clinical assistant professor in physical therapy at UBC, a passionate early adopter of patient-oriented research. She has co-built information resources with patient partners such as Heart Hub, website for persons making heart transplant treatment decisions. The Child Development and Rehabilitation website for children and youth with neurodiversity and disability, and Health Link BC Active for Health Physical Activity Toolkit for persons with chronic conditions. The work presented here is associated with her former role as the senior leader of co-leading research and knowledge translation programs at BC Children's and Women's Hospital with Miranda. Miranda is a nurse clinical scientist at BC Children's Hospital and Health Center and a CIHR postdoctoral fellow. Miranda's passion is in supporting clinically led research by walking alongside nurses, scholars, and communities globally in mentoring, collaborating, and co-creating research that is relational, participatory, and contextually grounded. Her work strives to uplift lived experience, resist dominant paradigms, and nurture knowledge rooted in place, purpose, and relation. Christy Caldwell is a senior advisor at the Organ Donation and Transplantation Research Foundation of BC and is a heart transplant recipient whose lived experience within the healthcare drives her commitment to advancing research that is accessible and meaningful for patients and families. She serves on the BC Patient Engagement Research Collaboration, supporting the integration of patient-oriented research lens into practice-based research initiatives. So each presentation is going to be 30 minutes. So these ladies here are going to give a 15-minute presentation, and then we'll open it up for some Q&A. I'll just keep an eye on the time, and maybe I'll just kind of just give you guys a little heads up when we're getting close.
Super.
All right, I'll just hand it over to Christy.
All right. Hello, everyone. Thank you for joining us today for our presentation on building a patient-oriented, practice-based research learning community in BC. Before we begin, we would like to acknowledge with respect and humility that we are joining today on the traditional and unceded lands of the Musqueam, Squamish, and Tsleil-Waututh nations. But that we also work and play on many diverse territories across our province, and so we gratefully acknowledge the deep histories, the living cultures, as well as the lasting contribution of Indigenous peoples who have cared for these lands since time immemorial. And in our discussion today, we intend to explore with you a little bit about who we are as a group, as well as the impetus behind this project, and also how we worked hard to ensure that this project was both meaningful as well as inclusive, and we'll also highlight some of those key impacts and important lessons learned, not only from the project itself, but also from the process that we endeavored along the way. Now, we know that in order to really appreciate the true essence of this work, it's helpful to understand what do we mean by a patient-oriented, practice-based research, or PBR for short. We will be using that acronym throughout our discussion today. So PBR equips clinicians with the training, the mentorship, as well as the funding to undertake health research in their clinical roles, which helps to drive improvements in patient care, as well as healthcare service delivery. And the vital strength of PBR programs is that it really values partnership. So it sees patients, families, persons with that lived and living experience as integral collaborators to the overall research process and the overall system. But moreover, it can also enable a learning health system approach by helping to reduce that research production to healthcare delivery gap that can exist. And I do also want to provide a little bit of sort of backstory on who we are as a group, because these groups, the two groups I'm going to speak to, have really spearheaded this important initiative. And so we have our POPROC, so okay, let me get this acronym right. So the PBR, patient-oriented practice-based research collaboration. And so actually prior to 2020, PBR programs did not readily adopt a patient-oriented research approach that was consistent across the various programs. So this actually meant that patient-oriented research was not being consistently done and that patient-family partners were not being meaningfully engaged in those individual research projects. And this is important because the BC Support Unit was instrumental. They recognized this and they brought about the safe space in which these programs could come together and really share their resources, but also align their efforts and also build capacity for that patient-oriented research. And that is where that pop rock comes in. But I think it was also really important to note that central to this process and to the success of this initiative was recognizing that those patients and those families, they needed to be involved right from the ground up, which is where that PERC, so Patient Engagement Research Collaborative, came in. I think I've got the two C's mixed. They may be mixed up, they may not be. We always get them a little confused, but we have our PERC. So our PERC consists of patients and families with diverse lived or living experiences of our healthcare system, but they also possess some capacity of experience in a PFP space in health research. So they came together and they also represent the diverse health organizations that are part of the larger pop rock. And so together, those two groups have worked to really actively create a shared patient-oriented research excuse me, approach to doing this work. So they developed that shared curriculum, those evaluation tools, and what this has meant is that patient and family partners are far more readily engaged in the governance in those individual projects, as well as in helping deliver the training to the clinicians and to supporting the mentorship process. So they've served to support the other patient and family partners in each of those organizations. But beginning in 2024, it was recognized that this coalition wanted to further advance that patient-oriented research approach by helping to establish more of a learning health system. Or no, sorry, not learning health system, learning community. And that's actually what Miranda and Kim are going to speak a little bit more to what that specifically looked like.
Thanks so much. I know so many terms, it's a lot to take in, but we got very excited about creating this learning community. And so we were very fortunate in acquiring a Michael Smith Health Research BC Nurses Union Convening and Collaborating Fund to support this mission. Our co-investigators included representatives from each of these PBR groups, as well as our patient partners. And so we have representatives from all of them. What we planned were 3 virtual convening and collaborating sessions to bring together these patient partners, healthcare leaders, researchers, healthcare professionals, and teams that are leading or perhaps thinking about whether they might like to lead a PBR program in their health organization. We established a patient, so the idea was to establish this patient-oriented practice-based research learning community and also to collectively think about how we might build strategies for sustaining, spreading, and evaluating the programs in BC. Through this, we hope to cultivate a research-supportive learning health system to really improve patient experience and outcomes, clinician engagement and retention, health services, and equity. We went about this taking notes from the way that SPOR had already taught us to best approach and think about how we engage meaningfully. Our guiding principles were those of being inclusive, safe, and supportive to all. And intentional efforts were made to really decolonize our power structures and create an equitable space for all participants, inviting all perspectives. To enable this, we used participatory methods for engagement, and I'll talk a little bit more about what those were. And we also leveraged technologies to bring people together from across the province. We used Zoom so that we could do this, Miro to capture ideas, and a Padlet website as a common landing space so we all had a place to go to find those resources. The BC Support Unit played a very key role in these initial stages, supporting and funding us in our early relationship building, because as we all know, relationship building takes intention and time, and in planning and consulting with the PERC so that we were better prepared when our funding came through and we were moving forward with this ambitious project. Our approach, this participatory approach, that was chosen for 2 of the 3 convening and collaborating sessions to establish this learning community were world cafes. and these were conducted virtually. They're participatory engagements where people come together in discussion groups of about 4 to 6 diverse participants, where they share perspectives on questions that matter. So if you can visualize sitting around a cafe table with your chosen coffee, tea, hot chocolate, this is the idea, where we're deeply listening, we're encouraged to understand, reflect, link, connect, and record ideas, and really create that safe, possibly a little informal space to contribute. Participants rotate around between the different groups for each of the questions, so there's an opportunity to cross-pollinate perspectives. Amanda, our facilitator, pictured bees going between different flowers as we thought about how this might happen. So the first of those World Cafes was very much about fostering partnerships, knowledge exchange, and co-designing the strategies for which we might optimize, sustain, and even spread programs to other health organizations in BC. Our core working group consisted of 3 patient partners, representatives from those PBR programs, and a representative from the BC Support Unit. And they played an important role in refining our questions, reviewing our preparation materials, refining our follow-up communication, even revisioning how it might happen. So it had to be a very collaborative approach, and sometimes we were redirected and moving in a slightly different direction, which was all good. We had a larger advisory group that reviewed our plans and supported us by inviting participants from their organizations and outside those organizations as they saw fit, really leaning on reaching out to research and knowledge translation programs and researchers and others who could contribute, including patient partners who represented that broader perspective. This is an example of how messy it can get sometimes as you're recording what happens. And the reason it's that way is because when we were doing this, we didn't want ideas to be funneled through a facilitator. We were democratizing how we put those ideas down, and everyone was invited to come together and put their ideas on their Miro board so that we were democratizing that harvest. To facilitate this, we had training videos and one-to-one sessions offered to our patient and family partners and perhaps others who were less familiar with the technology. And during the session, we had an informal and fun practice session that was integrated to familiarize everyone in how to use the technology. Also important from our perspective was to make sure each session was open with an elder providing us with learning, and that learning went through each of those World Cafes. And in fact, we were honored because one of our elders, Elder Ruth, stayed through that first World Cafe session and contributed to those tables of discussion. Our second World Cafe focused on creating that common equitable evaluation framework that would help us make visible the impacts and outcomes of PBR. There was a real desire from everyone who was involved to think outside the box, maybe even throw away the box, and consider what evaluation could be beyond traditional research metrics. Storytelling was emphasized in this inclusive approach. During the World Cafe, each participant was invited to share a short story that involved or imagined a meaningful impact that they had observed or experienced from PBR. While they were telling the story, the other participants were invited to document those impacts that they were hearing through the stories. So we were harvesting those themes that were coming through as people were talking about those experiences. And this is what it looked like here on our Miro board from a very vibrant group. Participants were not only providing the information in this case, they were supporting, analyzing, and making sense of what was brought through from the stories shared. In their discussion tables, participants themed the impacts using tags like improving patient experience and outcomes, strengthening human health resources, enhancing health equity, or decolonizing health systems. Those were some of the tags we used. And we didn't just limit that. Some participants were invited to suggest other themes that would represent the outcomes and impacts that they were hearing through the stories that were shared with the group. The harvest from this work is now being used to form this evaluation framework. And as I said, this includes some unique perspectives and unique ways that go beyond traditional metrics to reflect the meaningful changes that can result from PBR. Our final session was about collaborative action planning to advance PBR in BC. And to do this, we used an open space technology approach. I know, another term. What it really means is we're thinking about everyone being empowered to contribute. So in accordance with open space technology approach, all participants were invited to set the agenda and priorities for collaborative action. So this was very much about moving the power from us as the organizers to all of those who were engaged in these collaborative sessions. Those who recommended a discussion topic or an action led a virtual room to create a plan for what possible next steps might look like. And participants were invited to choose sessions where they wished to contribute. They were even invited to move between sessions if they chose to. They were reassured that was not going to be seen as rude. Collaborative leaders who identified actions were then brought together following this session to support the momentum of this work. I'm now going to move on and give Miranda the opportunity to share more about the feedback and the learnings from this work.
Thanks, Kim. Now that Christy and Kim have done all the heavy lifting, I get to come in with the fun part of what happened in the end. So thank you both. So we gathered our feedback using the public patient engagement tool with some key quotes that we collected here on the screen. So the majority of our respondents overwhelmingly agreed that they were able to express their views freely and that they did feel heard, not only during the sessions, but also in our response to their comments, sometimes ahead of the sessions, in our engagement and reaching out, but also after the sessions. As one patient and family partner said, safe spaces were created and facilitated, so I felt very much seen and heard. And another example, I'm struck by both the level of engagement and energy. Everyone was very invested. It's such a great experience being involved, and I'm learning so much. So this mattered really important to us because that was our intention, to build relationships, to build partnerships, and to work collaboratively, building on all of the amazing work that's been done by the Pop Rock, the PERC, and the BC Support Unit. So of course, we're still always unlearning and learning in our roles, and this project also offered a lot of important insights for us. As others have mentioned, I've heard this theme throughout the day, it really does take time to build relationships and connect with people. This wasn't done just for the sake of this project. This built on many meaningful relationships, including Kim and Christy here, across a variety of projects and spaces that have been going on for a long time. So we want to acknowledge, though, that it's really important to take the time to do that and to meaningfully connect. It was also exceptionally amazing and helpful for us to have a facilitator who shared very common values and principles of patient-engaged research and really challenging different power hierarchies, accessibility, inclusion, and her values and experience in engaging in this type of methodology and supporting us throughout all the technologies and helping to guide us through some of the unknowns and respond to our participants and patient family partners in a meaningful way. And of course, with all of this came time. It was really, really important for us to be able to co-design the sessions together, to let go of those pieces of control, as Kim mentioned, and really guide the project to where it needed to be for those participants and for our patient and family partners. And we really worked hard to create a lot of materials to support the participation, to have those accessible to everyone participating, and really follow up with feedback and our intended actions that were provided by the participants. And that really involved our flexibility that we felt was key. Sometimes folks couldn't make sessions, the timing didn't work, things came up last minute, and so we took the extra time or important ways to engage with participants when they couldn't be included. So sometimes that meant, meeting one-on-one after the sessions or offering different opportunities to provide input or feedback into the work. So, and for those who are interested in seeing the results of the 3 sessions we put together, here's the very first look, at least publicly, of the graphic design that was created. So this was created as a request from our participants to have a visual that represented the work that folks could take up in their own organizations or their own initiatives or their own experiences that would be meaningful to them, sharing key messages from across all 3 of the sessions. So the key was to distill these messages for all the different audiences that we intend to discuss about patient-oriented practice-based research. So our patient partners, our clinicians, our leaders, our PBR leaders, and also our healthcare leaders. So an additional recommendation also was for video. There we could really capture the experiences of patient and family partners in engaging in that work. So that's something we're hoping to work on next. And in closing, we're really grateful and would like to acknowledge the funding we received to conduct this work from Health Research BC and the BC Nurses Union. And tons of acknowledgements that we have for Amanda, our amazing facilitator, many of our working group members, quite a few of who are in the audience here, and of course the Pop Rock and the PERC and the BC Support Unit, as well as our partners across Canada in the Canadian Practice-Based Research and Innovation Network. Thank you.
Thank you, all 3 of you. We have a few minutes, so does anybody have any questions for the group here? You guys are going to be here the rest of the day too.
Yeah,
so
we're not going away.
yeah, you can seek them out again, but it's really cool to see how the original patient-oriented research has kind of expanded beyond what it kind of started as back in the day. So that's really great. So once again, thank you to Cam, Christy, and Miranda for your great talk. Thank you. Thanks.